Welcome to Clinical Capsules, where we bring you the same evidence-based insights you trust from TRC Healthcare, now in podcast form. We're thrilled to launch this new series as we celebrate 40 years of keeping healthcare professionals ahead of critical medication updates and guidelines. Every second and fourth Tuesday, our expert editors from Pharmacist Letter, Prescriber Insights, and Pharmacy Technicians Letter will break down the most impactful clinical developments, giving you clear, actionable takeaways in just minutes. Today, you'll hear an excerpt from our December 2024 Pharmacy Essential Updates Continuing Education webinar series. In this segment, Assistant Editor and Pharmacist Rachel Cole examines the management of resistant hypertension. With that, let's get started.
Now let's get into the topic of managing resistant hypertension and refresh ourselves on how to best manage this often hard to treat condition. So our article on this topic talks about a newly FDA-approved drug called aprocitentan or Trivio. This dual endothelin antagonist is indicated for use in patients with blood pressure above goal, despite being optimally managed on other antihypertensives. The mechanism may sound familiar as we have drugs of this class approved for pulmonary arterial hypertension, like bosentan or Tracleer, but aprocitentan is the first approved in resistant hypertension. Before diving further into details on this single drug, let's review the approach to treatment of resistant hypertension, and we'll talk about where Trivio may fit in. So resistant hypertension is defined as when patients need more than 3 drugs from different classes, including a diuretic, to control blood pressure. And the goal blood pressure that patients will aim for can vary, but for many patients, we'll be aiming for a blood pressure of less than 130/80. So we can recommend a stepwise approach to help manage the care of patients with resistant hypertension. The first step is to evaluate factors that may be contributing to elevated blood pressure. The next step is to optimize first-line meds, and then after that, we can help individualize add-on medications. So let's take a closer look at each of these steps and start by evaluating factors that may be contributing to resistant hypertension. So we want to start by looking at adherence and whether the patient's taking the blood pressure medications they're prescribed. This is a concern in up to 80% of patients with resistant hypertension and can play a role in pseudo-resistance, where the patient may not truly need more than 3 meds to control blood pressure, but simply because they're not taking the meds that they are prescribed. So especially for us as pharmacists and technicians, we're in a key role to help identify patients that may struggle with adherence and to ask, how often do you miss a dose? And then we can help tailor solutions to the patient, such as considering combination medications like lisinopril plus hydrochlorothiazide if the patient's already stable on the 2 separate meds, to help simplify regimens, reduce pill count, and possibly reduce cost or copays, or ensuring patients know why it's important to take blood pressure meds, or recommending pill boxes or smartphone apps to help with doses, just as a couple examples. But I know many pharmacists and technicians are masters at helping patients with adherence, so I'd love to hear other ideas you may have too. And then beyond adherence as the first step, there are a number of other factors that could contribute to resistant hypertension that we can be thinking about. For example, sleep apnea or obesity or chronic kidney disease, or asking about dietary sodium intake, since it can be easy to overlook hidden sources of sodium. And patients should usually aim for less than 2,300 milligrams per day. Also asking about smoking or excessive alcohol use, which can also contribute. And then we're also in a good spot to look for medications or supplements that could increase blood pressure. For example, we can ask patients about OTC or prescription NSAIDs or decongestants, or we can look for stimulants such as for ADHD or some antidepressants such as SNRIs. We can also ask about supplements or other products that could affect blood pressure, such as bitter orange or black licorice, which patients may not expect could raise blood pressure. So, again, a good opportunity that's unique to our role to help identify potential factors that could be contributing. Also, review how blood pressure is being measured, which can contribute to pseudo resistance if the blood pressure simply isn't being measured properly. So, we want to ensure proper preparation and technique. For example, patients should rest quietly for at least 5 minutes before checking blood pressure. They should sit in a chair with back supported, both feet on the floor, and legs uncrossed, and their arms should be supported and resting at heart level. We also want to ensure that they're using proper equipment, including the correct cuff size. For example, the bladder of the cuff should be at least 80% of the way around the patient's arm. And if patients are checking their blood pressure at home, we should recommend a properly sized arm monitor, which are the most accurate, and discourage wrist monitors except for a patient with severe obesity. If a patient does use a wrist monitor, emphasize that it must stay at heart level. And of course, especially if patients have resistant hypertension, we want to reinforce exercise, a healthy diet, weight loss, smoking cessation, and even things like good sleep habits and reducing stress can help too, since these factors could be contributing to high blood pressure. Now, the next step, after ruling out other factors that could be contributing to resistant hypertension, is to help optimize the medications the patient's already taking for their high blood pressure. And there are four main classes of first line meds for hypertension, which are an ACE inhibitor, such as lisinopril, or an ARB, such as losartan, a calcium channel blocker, like amlodipine, and a thiazide diuretic, such as hydrochlorothiazide. These meds are all first line options for high blood pressure in general. And we said that resistant hypertension is defined as needing more than three drugs, including a diuretic, to control blood pressure. So patients with resistant hypertension are likely going to be on an ACE inhibitor or an ARB, calcium channel blocker, and a thiazide. And we can help ensure doses are optimized for those first line meds. And there's some other fine tuning we can consider too. For example, we can suggest taking at least one non diuretic blood pressure med at bedtime, especially if some blood pressure readings are high in the morning, because patients with resistant hypertension often have blood pressure that doesn't dip at night like it should. And this relatively simple change can help the patient reach their blood pressure goal. But again, consider adherence, since that's the best predictor of blood pressure control. And if introducing a bedtime dose is going to make it less convenient for patients, or possibly affect them taking the med altogether, then this may not be the best option. We can also help fine tune the choice of med if needed. For example, if a patient's on hydrochlorothiazide as their thiazide diuretic, we could suggest switching to chlorthalidone or indapamide instead. These are longer acting than hydrochlorothiazide, and they have more evidence of cardiovascular benefit. But also consider the practicality of using one of these other thiazides. For example, there aren't many combo products available with chlorthalidone and none with indapamide in the US. So if adding another pill to the patient's regimen may affect adherence, that's something to consider. And then for patients with severe kidney disease, with the creatinine clearance below 30 mils per minute, it's preferable to switch to a loop diuretic, like furosemide instead, since they're likely to be more effective in these patients. And then after we've helped optimize and fine tune those first line meds, the next step is to think about whether additional blood pressure lowering meds are needed, and if so, which ones to use. And this will be an individualized process. For most patients, in general, suggest adding spironolactone next. It's considered a first-line add-on because it's more effective at lowering blood pressure in patients with resistant hypertension than alpha or beta blockers. And spironolactone has been studied for blood pressure control specifically in patients with resistant hypertension. But we do want to advise monitoring kidney function and potassium, since spironolactone can raise potassium and may affect kidney function, especially in combination with the ACE inhibitor or ARB that the patient is already taking. So, adding spironolactone will usually bring patients to 4 medications total for lowering blood pressure. And then after that, if we're thinking about adding a fifth medication for resistant hypertension, then the choice is really going to come down to comorbidities, such as whether a patient could benefit from a med for another reason and get a 2-for-1 benefit, and side effects. And some of this can be more art than science, along with really individualizing the choice for your patient. For example, consider an alpha blocker like doxazosin for patients with benign prostatic hyperplasia or BPH, since alpha blockers are often used to help improve urine flow in these patients and may also help lower blood pressure. But caution about dizziness and orthostatic hypotension or blood pressure that quickly drops when getting up from a sitting or lying down position. Or you may lean toward a beta blocker like metoprolol if a patient also needs a medication to help prevent migraines, since beta blockers are a first-line option for migraine prevention. Or a beta blocker may be needed for patients who also have heart failure or after a heart attack. But patients may need to monitor their heart rate. Or for some patients, consider carvedilol or labetalol, which are beta blockers that also block alpha 1, since some evidence suggests that these might lower blood pressure a bit more and could be worth a try instead. And then you might think about clonidine or guanfacine to help lower blood pressure if other add-ons are not tolerated. But again, we need to individualize and think about side effects. For example, either of these could cause dry mouth and sedation, and these meds need to be tapered if they're stopped to limit rebound hypertension. And the choice will be based on cost, dosing, side effects, and other factors. For example, clonidine tablets require twice daily or 3 times daily dosing, so a clonidine patch may be more convenient than other tablets, but the patch can also cost more. Now let's circle back to aprocitentan or Trivio, the newly approved medication for use in combination with other antihypertensive medication when the patient is not reaching blood pressure goals. This dual endothelin antagonist is only available through the Trivio REMS program due to embryo-fetal toxicity, so prescribers and pharmacies must register with the program, which usually involves completing some training, and also consider the possible cost to the patient before prescribing. So, evidence suggests the aprocitentan 12.5 milligram tablet once daily decreases systolic blood pressure by about 4 millimeters of mercury versus placebo after 4 weeks in patients with resistant hypertension not controlled when taking at least 3 antihypertensives. And safety and efficacy past 48 weeks isn't known. Aprocitentan can be used with spironolactone. It has no significant drug interaction and does not cause hyperkalemia. The most common adverse effects are fluid retention, anemia, and hepatotoxicity, so monitoring hemoglobin and weight is recommended. See our article for more details. And finally, here are a few helpful pearls when dispensing aprocitentan. After registering with the Trivio REMS program, authorization must be obtained for dispensing each prescription. Keep patient profiles up to date with pregnancy status, and the patient should be counseled to conduct a monthly pregnancy test and confirm that patients of childbearing age are using contraception prior to, during, and a month after the last dose. And make sure the pharmacy can get the medication before billing insurance and anticipate rejects, since it may only be supplied through specialty pharmacy. And the tablets should be kept in the original container with the desiccant packet and the cap tightly closed. So, on our website, we have this frequently asked question called Treatment of Hypertension, which has more details about some of those meds that aren't used as often for high blood pressure, such as hydralazine or minoxidil, and sections on treatment of hypertension in patients with diabetes and resistant hypertension, and other considerations with med combos to avoid.
We hope you enjoyed and gained practical insights from listening to this presentation. Be sure to follow or subscribe, rate, and review this show in your favorite podcast app. Or find the show on YouTube by searching for TRC Healthcare or clicking the link in the show notes. While you're there, check out our other TRC podcasts like Medication Talk and Rumor vs. Truth. Also in the show notes, we've linked directly to a few of the excellent resources mentioned today, available to subscribers of Pharmacist Letter, Pharmacy Technician's Letter, or Prescriber Insights. On those websites, you'll also find a lot more evidence-based, concise, yet comprehensive resources on this and other medication therapy topics. If you aren't already a subscriber, don't miss out on these resources. Sign up today to stay ahead with trusted insights and tools. We are an industry-leading, non-biased source of information and continuing education. And if you're a student, good news. Students can access a free version of Pharmacist Letter. We've linked to that directly in the show notes as well. Go check it out. Find out more about our product offerings at trchealthcare.com. You can also reach out to provide feedback or make suggestions by emailing us at contactus@trchealthcare.com. Thanks for listening to Clinical Capsules.